जाना चाहिए भाई में।
फ़ोन नहीं, फ़ोन मेरे लीड नहीं है मेरे पास, बैग में है वो, मैं लगाता नहीं कुछ।
friend and class
लाइट बंद करो, बोलेगी बोलेगी। हाँ
बंद कर रही
या तो यही होगा सर।
थोड़ा तो इधर आपको तो फोटो खींच देगा, इधर से खींचोगे
सर इधर से आएगा
अरे फेस भी था ना,
मतलब मेरे तो पैसा आएगा नहीं ना गा दी यार। कुछ इधर से खींचो, आपकी तो फोटो खींचनी है। लाइट बंद करना तो लाइट
थोड़ा सा
बंद करना था। मैं उस साइड से उस साइड चले।
Assembled here this morning to witness the second Dr. K.D. Gupta Memorial Oration 2023. This oration marks a tribute to one of the most senior and distinguished physicians of Rajasthan, former principal of Sardar Patel Medical College, Bikaner, Param Pujniye, late Dr. Krishna Dayal Gupta. It gives me immense pleasure to welcome and invite to the dais our chief guest and today's orator, Professor of Cardiovascular Medicine at Imperial College, London, and co-director, International Center for Circulatory Health, world-renowned authority on hypertension, Professor Neil R. Poulter. Dr. Poulter shall be delivering the second Dr. K.D. Gupta Memorial Oration on the topic, Raised Blood Pressure, Anecdotes, Interpretations, and Misinterpretations. Please give a huge round of applause as I invite the other dignitaries to join him on the dais. We are extremely pleased to welcome the proud sons of late Dr. K.D. Gupta and conveners of this oration series, enormously renowned physician and academician par excellence, Dr. Rajiv Gupta, and his brother, a legend in the field of translational medicine, Professor of Medicine, Hepatology and Pathology, Dr. Sanjeev Gupta from New York. Most respectfully, I welcome the Emeritus Chairperson of Mahatma Gandhi University of Medical Sciences and Technology and proud student of Dr. K.D. Gupta, Dr. M.L. Swankar. Please join me in welcoming the Chairperson cum Chancellor of Mahatma Gandhi University, Dr. Vikas Chandra Swankar. I also welcome and invite the Vice Chancellor of Mahatma Gandhi University, Dr. Achal Gulati. The Pro Vice Chancellor of our university, Dr. V.K. Kapoor. Principal and Controller, SMS Medical College, Dr. Rajiv Bagaratta. Chief Advisor to the Chairperson, Mahatma Gandhi University, Dr. Sudhir Sajdev. And Dean, Principal and Controller, Mahatma Gandhi Medical College and Hospital, Dr. N.D. Soni. Before we begin with the program, may I request our chief guest and other dignitaries on the dais to light up the lamp as a mark of auspiciousness, positivity, and wisdom, and also to pay homage to late Dr. K.D. Gupta ji.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव.
Let us all just join our hands to seek blessings of Lord Ganesha.
सर्वदा नमो नमः श्री सिद्धि विनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगल मूर्ति मोरया. ओम गणपतिये नमो नमः श्री सिद्धि विनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगल मूर्ति मोरया. ओम गंगण नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया
Thank you all. Ladies and gentlemen, as I mentioned, our chief guest and today's orator, Professor Neil Poulter, he is Professor of Cardiovascular Medicine at Imperial College of London and co-director of the International Centre for Circulatory Health and founder director of Imperial Clinical Trials Unit at London. He is a world-renowned authority on hypertension and former president of International Society of Hypertension and the British Society of Hypertension. We welcome you, sir, but no welcome is complete without the presentation of flowers. And for this, first and foremost, I request the Emeritus Chairperson of Mahatma Gandhi University of Medical Sciences and Technology, Dr. Emil Swankar, and Srimati Meenaji Swankar, to please present a floral bouquet and welcome Dr. Neil Poulter. Now I request the Chairperson cum Chancellor of Mahatma Gandhi University, Dr. Vikas Chandra Swankar, and Mrs. Harman Swankar to please present a floral bouquet and welcome our chief guest. I next request the Vice Chancellor of Mahatma Gandhi University, Dr. Achal Gulati, to present a floral bouquet and welcome Dr. Poulter. And I think the applause should continue. We are happy to have with us the Principal and Controller of SMS Medical College, Dr. Rajiv Bhagaratta. I request Dr. Rajiv Bhagaratta also to present a floral bouquet and welcome Dr. Neil Poulter. I now invite on the stage the Director of Hospital Administration, Dr. Shobhit Swankar, and Mrs. Jayashri Swankar to please come up on the stage and present a floral bouquet to welcome our chief guest. And last but not the least, I request Dr. Rajiv Gupta and Mrs. Madhu Gupta to please present a floral bouquet and welcome our orator and chief guest, Dr. Neil Poulter. I now request the chairperson cum chancellor of our university, Dr. Vikas Chand Swankar, to formally welcome all the guests and deliver the welcome address.
Good morning. I, on behalf of Board of Management of Mahatma Gandhi University, welcome all of you to this auspicious and the very prestigious Dr. K.D. Gupta Memorial Oration, the second. Professor Neil Poulter, chief guest of today's program and the orator for this second Dr. K.D. Gupta Memorial Oration. Professor Dr. M.L. Swankar, chairperson of Mahatma Gandhi University, and my father. Dr. Achal Gulati, Vice Chancellor of the Mahatma Gandhi University. Dr. Rajiv Bagratta, Principal and Controller, SMS Medical College. Dr. Rajiv Gupta, a renowned name in preventive cardiology. Dr. Sanjeev Gupta, Professor of Hepatology and Pathology, the Elazar and Feige Reichert Chair in Translational Medicine at Albert Einstein College of Medicine, New York. Dr. Sudhir Sachdev, Chief Advisor to the Chairperson. Dr. V.K. Kapoor, the Pro Vice Chancellor. Dr. N.D. Soni, Principal, Mahatma Gandhi Medical College. Persons of eminence and dignitaries in the audience, guests, and those who are watching the live telecast of this program online. My father and Chairperson Emeritus of Mahatma Gandhi University was inspired and influenced by Dr. K.D. Gupta. Dr. Gupta has been his teacher in the early years of medical college. This lasting impression that the personality of Dr. K.D. Gupta had upon my father was one of the initial stones of foundation of this institution. Buildings are made with cement and bricks, but the institutions are made with noble ethos and principles, and it is Dr. K.D. Gupta who instilled the values of providing quality medical education to the prospective students and offering the best possible and latest medical treatment to the patients at the same time. God has been extremely kind to us as doctors that we can teach and practice at the same time and yet make a reasonable quality of living. There cannot be a better example than Dr. K.D. Gupta to personify this. Dr. K.D. Gupta was born in 1922 in Bikaner, graduated in medicine from the King Edward Medical College in Lahore in 1946. He did his residency in internal medicine from the Government Medical College of Punjab University in 1949. In 1951, he proudly taught the first graduating class of SMS Medical College, Jaipur. Dr. Gupta portrayed, rather personified, many roles effectively, that of a brilliant teacher, an outstanding yet a very compassionate clinician, and that of an astute administrator. Thousands of his undergraduate and postgraduate students learned the great art and science of medicine from him through his remarkable clinical teaching and interpersonal relationship building skills. Dr. Gupta had a passion of clinical academic research. He had more than 200 publications in medicine in the fields of allergy and immunology, liver diseases, and cardiovascular pathophysiology in national and international journals. We at Mahatma Gandhi University of Medical Sciences and Technology have dedicated our library in his name by the name of Dr. K.D. Gupta Knowledge and Resource Center of the Mahatma Gandhi University. Today, we are very fortunate to have Professor Neil Poulter amongst us to deliver this prestigious oration. As a strong and scientific proponent of preventive cardiology, there couldn't have been a better person for this occasion. Dr. Poulter is a professor of preventive cardiovascular medicine at Imperial College, London, where he is also the co-director of International Center for Circulatory Health. He has contributed chapters to several major textbooks and published over 700 papers in peer-reviewed medical journals, including co-authoring several sets of national and international guidelines. It gives me immense pleasure to share that Professor Poulter was identified as being among the top 1% most cited academics in clinical medicine in 2014 and among the top 0.1% most cited researcher between 2008 and 2021. This is a huge achievement. And sir, we are indeed privileged to hear you live in person for this oration from your good self. Most humbly, and with your kind permission, I wish to utilize this opportunity to submit a brief introduction about our institution. The foundation stone of the Mahatma Gandhi Medical College was laid in the year 2000, and the hospital was subsequently inaugurated in the year 2001. The first batch of MBBS students joined in 2001, and subsequently the institution evolved into the first private exclusive medical university of Rajasthan in 2011. Since then, both hospital and medical college have undergone many phases of evolution to come to this stage. The university envisions to develop into an institution of excellence at par with global standards in the field of healthcare and allied sciences, driven by top quality teaching, training, research, and innovation. The Mahatma Gandhi Medical College is approved by the Government of India and recognized by the regulatory body, the National Medical Commission, with 250 annual undergraduate seats in MBBS, more than 150 annual postgraduate, that is the residency seats in all medical specialties like general medicine, general surgery, OBGYN, pediatrics, and also the novel ones like the nuclear medicine, emergency medicine, palliative medicine, family medicine, etc., to name a few. We have an annual intake of 67 students in the super specialty DMMCH programs in cardiology, cardiothoracic surgery, hepatology, hepato-pancreato-biliary surgery, medical and surgical gastroenterology, medical and surgical oncology, clinical hematology, neurosurgery, nephrology, reproductive medicine, neuro and organ transplant anesthesia, etc., to name a few. The university's dental college is a DCI recognized postgraduate dental institution with 100 BDS admissions and 33 postgraduate admissions in various branches of dentistry annually. Sir, we have a postgraduate nursing college, a postgraduate physiotherapy and occupational therapy college, and offer various other courses in medicine and allied fields like hospital administration, health informatics, etc. Mahatma Gandhi Hospital is the NABL accredited teaching hospital of the university. It is one of the largest private hospitals in the state of Rajasthan, having more than 1,450 beds, and is a pioneer in the field of organ transplant. We have performed the first heart transplant, first liver transplant, first pancreas transplant, and first cadaveric kidney transplant in the state of Rajasthan, and one of the few medical colleges in the country doing all such organ transplants under one roof. The renal transplant team is doing almost 2 transplants per day, and we perform complex transplants like the 2-way and 3-way swab transplants and ABO-incompatible renal transplants. So far, more than 1,600 transplants have been done at the Mahatma Gandhi Hospital. We have an established live related donor liver transplant program and performing close to 5 transplants a month with good results. And so far we have performed more than 75 liver transplants. The credit for this goes to our digestive sciences team encompassing HPB surgery, hepatology, GI surgery, and the medical gastroenterology. With utmost humility, I submit before you that the oncology wing of the Mahatma Gandhi Hospital, the Shri Ram Cancer and Super Speciality Center, is the state's largest multidisciplinary oncology setup with almost 400 beds, equipped with latest devices like 2 high-end linear accelerators, a PET scan, 2 MRI scans, 5 CT scans machine, and is managed by a team of senior medical, surgical, and radiation oncologists. The Department of Clinical Hematology is running a successful bone marrow transplant program for neoplastic and thalassaemic conditions. In the coming few months, the center would be adding a cyber knife, another linear accelerator, and an additional PET scan machine at its premises, ready to be deployed in the service of the society. The Center for Neurosciences and Cardiac Sciences is routinely performing advanced and complex procedures, including the interventional neurological procedures, using the latest and modern equipments like intraoperative O-arm, mobile and intraoperative CT scanning, neuronavigation, and 3 state-of-the-art cath labs. The Department of Neurosurgery is performing the highest number of neurosurgery cases in Rajasthan and is steered by Dr. B.S. Sharma, one of the most experienced and senior neurosurgeon of India. The Institute's cardiac center has a very specialized and a competent team of 4 cardiologists led by Dr. Harshvardhan, Dr. Rajiv Sharma, Dr. Deepesh Agarwal, and Dr. Ramanand Sinha. The hospital is performing all kinds of complex adult and pediatric cardiac interventional procedures. I can state with pride that our team of critical care specialists, along with their team of residents, nurses, paramedical, and admin staff, worked tirelessly during the COVID-19 pandemic. I owe my sincere gratitude to them. Mahatma Gandhi Hospital was the largest private state government designated tertiary COVID care center in Rajasthan. Plan for the worst and hope for the best was the philosophy that time. The institute deployed large-scale infrastructure with over 1,000 beds, having piped oxygen supply up to 400 ICU beds with close to 150 ventilators, 5 ECMO units, state's largest oxygen generation plant, along with 3.1 kiloliter of liquid medical oxygen reserve. With the grace of Almighty God and blessings of ancestors and teachers like Dr. K.D. Gupta, well-wishers like you all, the constituent colleges of the university are amongst the most sought-after colleges amongst the student community. And the teaching hospitals, the Mahatma Gandhi Hospital and the Shri Ram Cancer Center, enjoy the reputation of being a high-quality, transparent, non-exploitative tertiary care center amongst the patient population and the society at large. The best way to find yourself is to lose yourself in the service of others, as said by our father of nation, Mahatma Gandhi. With this brief and humble introduction about the organization, I on behalf of entire Mahatma Gandhi University family, congratulate Dr. Rajiv Gupta, Dr. Sanjeev Gupta, and their families and his beloved students in the audience on this occasion, and once again formally welcome all of you to this event. May God bless us all. Thank you.
Thank you, sir. As already mentioned by our chairperson cum chancellor, Dr. Vikas Swankar, Dr. K.D. Gupta was a major force in the establishment of this institution. And to honor him, the Central Library of our university has been named as the Dr. K.D. Gupta Knowledge Resource Center. They say, better than 1,000 days of diligent studies is one day spent with a great teacher. Such a great teacher was late Dr. K.D. Gupta. And to witness his journey to become a great teacher and an inspiration for all his students, it's time now to show a brief documentary on the journey of Dr. K.D. Gupta.
Dr. K.D. Gupta was one of the most senior and distinguished physicians in Rajasthan who received his primary education in the village of Ballabgarh, Haryana, and completed his secondary education at the Government High School at the district headquarters of Gurgaon in the late 1930s. He then went to Lahore for further studies, which was a major educational and cultural center in North India. Dr. Gupta excelled in his studies at the DAV College in Lahore and was considered to be one of the most successful and brilliant students at the college. Subsequently, he was accepted at the King Edward Medical College in Lahore and graduated from there in 1946. Immediately after becoming a physician, he joined the provincial medical services of the Bikaner state, where he quickly made a mark in the presence of outstanding physicians led by the Venerable Professor Weingarten of tropical eosinophilia fame. This experience enthused him to obtain further expertise, and in 1950 he obtained an MD degree from Punjab University and joined the Rajasthan State Medical Services and was posted as a medical specialist in Kota. In 1952, he joined as a lecturer at the Department of Medicine at the newly established SMS Medical College, Jaipur, which was the first medical college in the state and was affiliated with the Rajasthan University. He had the distinction of teaching the first graduating class of the SMS Medical College and made a mark with an original style of teaching and was renowned for his clinical acumen and academic depth and breadth. In 1956, Dr. Gupta was awarded the prestigious Lederle International Fellowship in Allergy and Immunology and worked at St. Mary's Hospital, London and the Temple University, Philadelphia for 2 years. This overseas experience in academic medicine became an important forming event in Dr. Gupta's career. Upon his return, he started the first allergy clinic in India at the SMS Hospital in Jaipur, which was later taken up by other institutions in the country. In 1962, he was appointed professor and head of the Department of Medicine at the SP Medical College, Bikaner, where he went on to become the principal of the college and the Dean of Medical Studies at the University of Rajasthan. In 1977, he retired from governmental positions after having completed 31 years of highly distinguished service. Dr. Gupta had a lifelong involvement in basic and clinical research and had over 200 publications in fields of allergy and immunology, liver disease, and cardiovascular pathophysiology in national and international journals. His hypothesis of infections as a cause of chronic liver disease and gut-liver interaction is still a hot topic in hepatology. He was honored by several fellowships, state and national awards. He was an extremely popular teacher, and his lectures and bedside teaching methods inspired thousands of undergraduate and postgraduate students who remember his legendary clinical teaching and interpersonal skills. These students are spread not just in India, but far and wide across the globe. He was extraordinarily popular as a friend of students and an avid supporter of cultural activities, and his students still remember his captivating voice and mesmerizing rendering of songs and ghazals, which were an ever-popular star attraction at annual functions and picnics of the medical college. Students still remember the annual Holi festivities at his home with songs, dancing and gulab jamuns. After retiring, he settled in Jaipur as a consultant physician and was appointed as an emeritus professor by the government of Rajasthan. Moreover, he served as the chairman of the Rajasthan Red Cross, established the very first private blood bank in Rajasthan, and was also a guiding light in the setting up of the first private medical college, the Mahatma Gandhi Institute of Medical Sciences in the state, where the Central Library has been named after him. He remained busy until the very end with his clinical activities. Dr. Gupta's wife Kusumlata and 3 children, Rajiv, Sanjeev and Indu, survived him. His sons followed in his footsteps to take up medical studies, and he stimulated them to take up research and academic medicine. Both are now internationally renowned researchers. Dr. Rajiv Gupta in cardiovascular epidemiology and preventive cardiology, and Dr. Sanjeev Gupta is a specialist in liver diseases with a focus on the basis of liver regeneration, including cell therapy. Indu, the daughter, is actively engaged in social service and is a trustee of a leading NGO working for urban slum development in India. For Dr. K.D. Gupta, his family and his extended family of students were his pride and joy, and he loved to meet and sing and laugh with them till the very
After this mesmerizing, heart-touching documentary on Dr. K.D. Gupta, may I now invite Dr. Sanjeev Gupta to say a few words about his late father. Dr. Sanjeev Gupta, as already mentioned, is Professor of Medicine, rather Hepatology and Pathology, and the Eliezer and Feige Riker Chair in Translational Medicine, Albert Einstein College of Medicine, New York. Dr. Sanjeev Gupta.
Thank you so much, and I'm so honored to be here, and for so many of you to show up means a lot. But I think the first thing we need to do is to appreciate Indu's effort and give her another round of applause. The short story that you just saw summarizes, obviously, a long, many decades of work, and it's sometimes difficult to encapsulate all that one sees over many decades in just a few words. And so I'll have to not only be selective, but I'll have to say things that some of the people in the audience may end up correcting later on. But the first and most important thing I want to emphasize is how important and difficult it is to build careers in any field, but especially in medicine, where our training is long, our postdoctoral training is even longer, and the learning and growth really occurs throughout the careers. And that's where having the right mentorship, having the right leadership, having the right values, and having the right emphases on what is the good, bad, and ugly thing to do in careers is extremely important. And that's where he excelled, not by creating a recipe for one fits all, but recognizing that individuals matter and recognizing the individual's strengths and weaknesses, and then creating a support system, creating a value system, creating an educational experience, and learning from various sources despite limitations in so many ways of resources, despite limitations of overwork, despite limitations as we know now. And if you amplify them 10, 20, 30, 50-fold from those days in 50s, 60s, 70s when resources were limited, then it's easy to imagine how difficult it ought to have been at that time. I remember in those early days, because of resource constraints, every single person who got admitted in the hospitals would not have an X-ray of the chest because they were not easily printed, but to have a screening, just everyone would get lined up on the fluoroscopy machine and get a test done that way. And I remember how all the interns were doing all the urine testing and blood testing and providing those results the following morning, and how difficult it was to do all those tests for 12, 15, 13 admissions coming in every day. But then the importance of diagnosis that he taught people was not just through those tests and resource limitations, but paying attention to what matters, history, going over physical diagnoses, creating clinical pearls of wisdom through those experiences, and then transmitting them in his own inimitable way of teaching people. And I remember in his classes, oftentimes, he would give lists that if you see this, then these are the common things that you should think of first. Rare things at the end, and not to really be forgotten, but not to be emphasized as much. And through those details, then he created centers of excellence, I could say. For example, rare conditions such as porphyrias were common there, but was not diagnosed, and he created a way to look after all those cases. And did lots of investigations across the spectrum of what was being seen and created new knowledge that way. So across all those things, he was also very much aware ahead of the times of the value of well-being, of the concept that we say wellness, of the concept of mind-body connection. And that's where his emphasis on interpersonal corrections, how there should be entertainment, how there should be relaxation, how there should be song and dance, was an integral part of all students' experience as well. And then learning, going deep into every single area that got seen on a given day was another part of his activities. So those are the things that I think we need to emulate. We need to be good mentors. We need to be good physicians. We need to be good scientists. We need to be good leaders. And so I hope that's what we will continue in his tradition. And I thank you all for coming. And I thank especially the MG Institute for this honor that they're continuing.
Thank you so much, sir. It's a privilege to have the Principal and Controller of SMS Medical College, Jaipur, Dr. Rajiv Bagaratta, sir, with us. A cardiologist by profession, Dr. Rajiv is also an excellent writer and orator. I request Dr. Rajiv Bagaratta to say a few words on this occasion.
Good morning, everybody. I'm really thankful to the administration, to the Emeritus Chairman, Vice Chancellor, Chairperson, come Chancellor, and everybody from Mahatma Gandhi University to let me be part of this very emotional moment in the life of the great teacher and of his family. I don't know how to express myself the way the student gives respect to his great teacher. It's amazing, and it's so very inspirational and motivational for me to see a great disciple, that is Dr. M.L. Swankar, giving a tribute to his teacher in the way he does it. Not till a few years ago, I realized that Dr. Swankar was an alumnus also of Bikaner Medical College, because we always thought that he is an alumnus of SMS Medical College. Till the time we realized that the first year of his MBBS was passed, he entered the first year of his medical studies at Bikaner. His love towards the two institutions makes it difficult to let us make out which was his alma mater. That is his degree of emotion, degree of dedication to his colleges. I also understand that nothing can be a better tribute to one's father than the way Dr. Rajiv Gupta and Dr. Sanjeev Gupta and Mrs. Indu have done it today. The most fitting and the most flowing tribute to one's father is the way they have done it. I was watching the film which they have made. It's full of nostalgic tribute, nostalgic pictures, history, and the way the medicine should be practiced. Unfortunately, these days, we are losing that art of human touch, the human compassion. We have to realize that being in the medicine field, this part is the most important part of practice, of our learning, of our practice. And I bow myself to the great teacher who instilled this beautiful art, this magical art of practicing medicine by clinical diagnosis, by history taking, and by clinical examination. Come what may, any degree of artificial intelligence, any degree of instrumentation, any degree of medical equipments will not be able to replace this art of clinical diagnosis and clinical medicine. And this is the most important part. And I think if we are able to send this message across today to even a few students, the purpose of today's program will be served. And to this end, I also understand that the Mahatma Gandhi Medical College, under the able leadership of Dr. Sonkar, ML Sonkar sir, it's working overtime to have this particular philosophy of medical education amongst its students and amongst its faculties. I made it a point to be part of this today's oration because of the fact that I listened to Dr. Poulter's lecture 2 days ago. He's an amazing speaker. The way he converts his drab subjects to an entertaining discourse is a treat to watch. And I'm really lucky and thankful to the organization, to the administration, to let me be part of this beautiful event. Thank you. Thank you, everybody.
Thank you so much, sir. I now invite the Vice Chancellor of Mahatma Gandhi University, Dr. Achal Gulati, to address us on this occasion.
A very good morning to all of you. I just heard them saying they're ahead of time. Dr. Gupta, I think you're absolutely right. Ahead of time is something which really works out very well today. Somebody asked time one day, why do you keep on running so fast? Time said, if I stop, the world will stop. The time failed to realize a few things. He failed to realize the vision of Dr. K.D. Gupta, who was ahead of times. He was a physician par excellence, ahead of times. Time failed to realize the importance of Dr. M.L. Swankar, who was ahead of times by creating this institution of such magnitude. Time failed to realize the value of Professor Neil Poulter. He was ahead of times. He was ahead of the times. Why? Because medicine is preventive, promotive, and curative. Curative medicine is having its say. To augment that say, Professor Poulter, as preventive and promotive cardiology, has achieved a great sense in his lifetime. Why is this greatness there? There are so many doctors all over the world. Probably the average, if we take at the world, is something like 5.6 per 10,000 population. But then if we look at it in another viewpoint, this gentleman is a fellow of the Academy of Medical Sciences and one of the 1,261 fellows that have been awarded in the last, ever since this academy has been produced. Why was he given this fellowship? He was given this fellowship because of excellence in science, contribution to the society, and his wide expanse of achievements. That is what goes to this person who was ahead of time. Dr. Gupta sir, ahead of time becomes a key word over here. All of us are living in a fool's paradise. I mean, starting from me, I lived in a fool's paradise right from the beginning. Why? Because my idea of exercise was car to kitchen, car to restaurant, car to office, lift to the office, and that's it. When I was doing my MBBS, our cardiologist teachers taught us two things. Maximum number of fatal MIs occur early in the morning. Taken. Second number of highest MIs occur when you are doing very strenuous exercise, when you are unaccustomed to it. Fine. So my idea of preventive cardiology at that time was, don't get up early in the morning, don't do exercise, 2 risk factors are out. So I am living in a fool's paradise. Till my father, who passed out from the Harvard School of Public Health as one of the first preventive people in the country. So he infused this prevention blood in my field, in my life, And therefore, this concept about earlier that medicine is my food, to food is my medicine. That is what preventive medicine and promotive medicine is all about. We talk about COVID, we talk about so many communicable diseases, we talk about infections. But what about hypertension, cardiovascular disease, diabetes, mental health, cancer? These are non-communicable diseases, and these are the killers. I'm not afraid of my enemies at any point of time. I know how to deal with them. I'm afraid of my friends because I don't know what they're doing behind my back. Same way, hypertension, cardiovascular disease, diabetes. I thought they were my friends because they were absolutely silent, but they were silently killing me, and that is what the problem in today's world is. So what happens? Smoking, the body mass index, exercise, lifestyle, obesity, all of them are the killers today. Today, India is becoming a lead killer for 37% of our population going in for diabetes. Why? Hypertension, why? These are preventable issues. And then look what Neil Poulter did. His area of research went into hypertension, cardiovascular disease, hyperlipidemia, birth weight and cardiovascular diseases, hormones and cardiovascular diseases, diabetes, and ethnic studies. These were his areas of expertise. Am I right, Neil? So when these areas in preventive cardiology and promotive cardiology come across, we can easily think that the world is going to be a much better place to be in. Today is 3rd of October, 139 days prior to today. That is on 17th of May 2023, we celebrated the World Hypertension Day. Why did we celebrate? Because the WHO found it fit to look at it as that to detect higher blood pressure, to detect effects on health, and to significant control and prevention of this problem. And this is where this prevention is coming into the picture. We are stressed. Why are we stressed? Because we want to climb mountains. We keep on climbing mountains. But which mountains are we climbing? We are climbing molehills. We are making mountains out of the molehills, and that is what is adding to our stress every day. We talk about my hypertension, my diabetes, my mental stress, my this thing. It is not mine. They are not mine to be. These are things of my nature, and I need to change my nature so that I can prevent and promote my health. So to keep my heart beating, to make it better, and to convert it into a good place, we need to listen to what Dr. Neil Poulter said. We have a lighthouse, a beacon light over there. That beacon of light is taking us towards safety, towards promotive, and towards curative things. Statins are very good, but lifestyle, diagnosis, and management is what we need to look at, and that preventive and promotive cardiology, Professor Neil Poulter, thank you so much for being over here with all of us. I thank the memories of Dr. K.D. Gupta for letting us listen to this thing. Thanks to both the family of Dr. K.D. Gupta for being over here. Thank you, Dr. Swankar. Thank you, Dr. Vikas. Thank you, Dr. Kapoor. Thank you, Dr. Sajdev. Thank you, Rajiv ji. Thank you, everybody, Soni Saab, and all of you for being over here. And let us just listen to what Neil Poulter says and then encourage the preventive and promotive. Thank you so much.
Thank you so much, sir. I'm sure we all are eager to hear to the orator and to this Dr. K.D. Gupta oration. But before inviting Professor Neil for the oration, I now request the Chief Advisor to the Chairperson, Dr. Sudhir Sachdev, to please introduce the orator to the audience and share his achievements and accomplishments with all of us. Dr. Sudhir Sachdev.
Namaskar. Greetings of the day. Most respected Dr. Neil Poulter, Professor of Preventive Cardiovascular Medicine, Imperial College London, Co-Director of International Center for Circulatory Health, Founder Director of Imperial Clinical Trials Unit, London, former President of International Society of Hypertension and British Society of Hypertension. Honorable Emeritus Chairperson and founder of the Mahatma Gandhi University of Medical Sciences and Technology, Dr. M.L. Swarunkar, respected Chairperson cum Chancellor of the University and Chairman and Managing Trustee of the India Education Trust, Dr. Vikas Chandra Swarunkar, Vice Chancellor of the University, Dr. Achal Gulati, Pro-Vice Chancellor, Dr. V.K. Kapoor, Convener of the Oration, Dr. Rajiv Gupta, eminent preventive cardiologist and researcher, co-convener of this oration, Dr. Sanjeev Gupta, Professor of Medicine and Pathology, and the Elizar and Vash Stryker Chair in Translational Medicine at New York. Respected Vice Chairperson of the India Education Trust, Srimati Meenaji Swarunkar, Dean, Principal and Controller, Dr. N.D. Soni, and all the invited guests and dignitaries. I heartily welcome you all. It is not only a matter of pleasure, but also a matter of pride for us that today we have among us the world-renowned authority on preventive cardiovascular medicine and hypertension, Professor Neil Poulter. He very kindly accepted our request for delivering the second Dr. K.D. Gupta Memorial Oration 2023. Ladies and gentlemen, it is a great honor and proud privilege for me to present before you Professor Neil R. Poulter, a preventive cardiologist of international repute. He would be delivering oration on the topic raised blood pressure, anecdotes, interpretations, and misinterpretation. Professor Neil Poulter, a world-renowned authority on hypertension, qualified from the St. Mary's Hospital, London in 1974, where he trained in general medicine, following which he spent 5 years in Kenya coordinating a collaborative hypertension research program at the Wellcome Trust Research Laboratories in Nairobi. On his return back to the United Kingdom in 1985, he gained MSc in epidemiology with distinction from the London School of Hygiene and Tropical Medicine. He was then co-principal investigator of the World Health Organization Oral Contraceptive Case Control Study at University College London Medical School. Appointed as Professor of Medicine, Professor of Preventive Cardiovascular Medicine at Imperial College London in 1997, he is currently the co-director of the International Center for Circulatory Health. Professor Neil Poulter is the founder director of the Imperial Clinical Trials Unit, London, and is an honorary consultant physician and epidemiologist at the Poulter-Rose Cardiovascular Disease Prevention Clinic based at Hammersmith Hospital, London, where he is actively involved in the treatment of patients with hypertension and related problems. He was elected as a Fellow of the Academy of Medical Sciences in the year 2009. He has had the distinction of being former president of the British Hypertension Society and the president of the International Society of Hypertension. With over 650 papers in peer-reviewed medical journals, he has also contributed chapters to major textbooks in the field of cardiology. As a researcher in the field of optimal investigation and management of essential hypertension and dyslipidemia, he has played a major, significant role in several international research trials, including the ESCOT, Advance, Excel, Devote, Leader, and Creole. He is the chief investigator of the May Measurement Month and an annual global blood pressure screening campaign initiated by the International Society of Hypertension. I request you all to give a huge round of applause and welcome the world-renowned authority on hypertension, Professor Neil R. Poulter. most respectfully, I request you, sir, to please come to the podium and deliver this second Dr. K.D. Gupta Memorial Oration. Please, sir.
Make sure. Yeah, there's a pointer. Distinguished colleagues, guests, friends, ladies and gentlemen, thank you very much indeed for being here today. And I'd like to say a huge thank you to the K.D. Gupta family and the Swaraka family for inviting me here to give this second Professor K.D. Gupta oration. It is a true honor for me, and I'm totally delighted to be able to be here to deliver this oration. So, this is my title, and as you know, this is all about Professor Gupta. And we've heard what a great clinician and person he was. I chose to talk about raised blood pressure really because of the following, the contents of the next 3 or 4 slides. You'll see here, this is the number of people with raised blood pressure from 1990 to 2019. So over 30 years, the numbers estimated to have raised blood pressure go from 648 million, doubling to 1.28 million. And of all those people with blood pressure, the red ones are the ones that are undiagnosed. We'll come back to that. It's a pivotal piece of what I want to say. If we look around the world, the distribution, color-coded here, obviously varies dramatically depending on where you are in the world. The rates of hypertension vary. But importantly, around the world, 1/3 of women and 1/3 of men have got hypertension as of 2019. It is a massive global problem. And 8 years ago, I wrote that raised blood pressure continues to be the biggest contributor to the global burden of disease and to global mortality, leading to 9.4 million deaths each year. But if you use the more recent data from 2019, that 9.4 million deaths has now gone up to 10.8 million deaths each year. That's about 30,000 deaths per day due to raised blood pressure around the world. And I don't want to understate the horrors of COVID, which around the world has been a disaster, but COVID never killed 30,000 people per day and never will. By and large, COVID will disappear and go away and the deaths will get less and less, but it never killed 30,000 a day. Raised blood pressure is killing 30,000 a day now, and those numbers will increase because the world's population is getting larger, and on average, we're getting older. So how are we doing? Well, most of the hypertension around the world is in the low and middle income countries. And this is a hypertension care cascade for 4 regions of LMICs around the world. Doesn't matter which one we choose, the pattern is the same. Here you see, for Latin America and the Caribbean, the first column, that's 100% of hypertensives in the region. Next column, what proportion have ever had their blood pressure measured? And amazingly enough, about 10% haven't had their blood pressures measured ever. We then go on to the diagnosis of hypertension of these hypertensives. About half are diagnosed. What about treatment? About 40% are treatment. What about control to a relatively conservative target? Less than 1 in 5 of the hypertensives are getting treated. And you can see the red arrow is over the control rates all around LMICs for those who are lucky enough to get treated. So we're down to a small proportion of hypertensives around the world who are getting controlled. And that has to change. I'd now like to go back, having set the scene, to a couple of areas that I think are of interest and hopefully will of interest you. As was mentioned, between 1980, when many of you at the back were not born, in 1980 I was shipped off to Nairobi, Kenya for 5 years to try and set up a migration study, which came to be the Kenyan Luo Migration Study, nothing to do with the airline KLM. And here we go. This was the idea behind it. If you look at the association with age and systolic blood pressure, the normal, so-called normal thing in a westernized society is blood pressure to rise with age. In that setting, what you see here, the distribution of blood pressures here, the percentage distribution, you see a normal distribution, often skewed to the right, and we make an arbitrary cut point, and anyone above that level we call hypertensive. And we expect to get, you've just seen, a third of the adult population would be in that distribution. Now, first of all, I'd just like to say that is not normal, that's usual, that's common, but that is not normal. Anymore, it's normal to drink Coca-Cola and eat McDonald's and smoke. In terms of health and what we should be doing, we shouldn't be doing any of those things, but we do. And consequently, if you do those things, your blood pressure rises with age, and that drives us in to get this distribution of hypertension. So the idea was that I was to try and find a population, and there have been a few of these described, where once you got to adult maturity, blood pressure didn't rise with age. That is truly normal. That is what should happen if you don't drink Coca-Cola, if you don't add too much salt, etc. And if you have that setting, what I wanted to do, these are so-called unacculturated. That doesn't mean they don't have culture. It means they haven't taken westernized culture on board. So I needed to find a population like that. And if you did, what you found was their distribution of blood pressures was shifted over to the left, such that nobody had hypertension as currently defined. So my plan was, in this unacculturated, try and find one of these populations to see as they migrate from this setting to the westernized setting, which consequently shifted the distribution in the right-hand column to the solid westernized sort of distribution, and thereby to the etiology of hypertension. So whatever caused that was the cause of hypertension. That was the idea. So, as I said, at my third attempt, I found this population on the northeast shores of Lake Victoria in western Kenya. And you see the makuti roofs, the grass roofs, no electricity, no running water, a really beautiful area. I'll just take a little message now. One of the first people, I used to go there every month and do clinics and live there for a while. From my first year there, a case history, and it was a 26-year-old woman from the Luo tribe. She was slim, everybody was. She was a non-smoker, everybody was. And she lived in one of the 35 villages we looked at. And she came to my clinic, and through a translator, she gave a perfect history of angina. She had a tight girdle pain round her chest. And she got it when she was walking uphill from Lake Victoria. And I said, well, what do you do? And she said, I stop and I sit down. And what happens? Well, the pain goes away. Now, for those of you who know the Rose Angina Questionnaire, developed in UK, so this is sounding a lot like angina. So the differential diagnosis was either this was the first recorded case of angina in a young female from rural Africa, never ever reported before. Bear in mind, in 1980, in Nairobi, in the main city, if you had a myocardial infarction, if an African had a myocardial infarction, there was a huge grand round and everybody gathered round the bed to see this rarity. So this would have just been totally extraordinary. Well, was that the correct diagnosis? No, it wasn't. It turned out this lady carried a huge earthenware pot on her head full of water. So when she sat down with this pain she got in the chest, she took the water bottle off her neck and put it on the ground, and the pain went away. This was compressed thoracic vertebrae giving this girdle pain. And the thing I learnt about that was that the Rose Angina questionnaire, any test needs to be context specific for it to work well, and certainly the Rose Angina questionnaire would have led us down the wrong path. However, silly side story, there I was on the North Shores of Lake Victoria, and our plan was to track people leaving that rural area because we showed their blood pressures did not rise with age, no increase with age, but because the land was split up amongst the sons, land was getting short, they would want to go and join their cousins in Nairobi to get work, and they did. And this is Mathare Valley, this is downtown, one of the slums of Nairobi. And that was Dominic Onono, who was my main tracker, who would find people who'd left the rural area. Within a month of leaving that rural area, he would track them down and find them in the, I suppose it might be called townships these days, but it was the slums of Nairobi. That was Dominic. And to cut to the chase, what we did is we followed up a whole group of these migrants in the yellow, and this was their blood pressures before they left Nairobi. We'd measured them as part of rural screening. And then in yellow, you see, after 2 years, the distribution had shifted to the right compared to those in that pinky color who remained in the rural area. So you see a distribution shift. There isn't a subgroup who move over. It was just a shift in the distribution from a population where hypertension didn't exist at all. But within 2 years, that distribution had changed, and there were cases of hypertension amongst the migrants. What was it about? What caused it? Well, the best correlates of the change in blood pressure following migration are shown here. There was an increase in sodium chloride in the diet. They went from having ugali, a maize meal, as the staple, to bread. And bread, this sort of bread, was stuffed full of salt. They also reduced their potassium intake. Fruit and vegetables, easily obtainable in the rural area, was expensive in Nairobi, so that came down. Their pulse rates went up, presumably reflecting the interaction. This was the first time many of these people had interacted in the setting I showed you with tribes, different tribes, and they also tended to put on weight. And we put a hypothesis together to explain that, but pivotal amongst this was the increase in the sodium intake that they took. There are two main conclusions I'd like to just highlight here. And the first is that hypertension is not primarily a genetic disorder. In the rural area, there were no cases of hypertension. I was there for 5 years, 35,000 people. I never saw a case of hypertension. But when people moved into the city, the distribution shifted and some people got hypertension. And that was the importance of the individuals who got it may have had a genetic propensity to hypertension, or they may have more of the salt and less of the potassium. We couldn't tell. But without the environment, whatever the genes are, would not express themselves in the rural area. The environment was pivotal, with the one exception, a thing called Liddle's disease, which is exquisitely rare. This is primarily an environmental problem. And the second issue I'd like to highlight is that rural area, Saradidi, the whole rural area, everybody was on a low salt intake, very low salt intake. And recently there's been some rather average epidemiology suggesting that at the population level there may be a danger in taking salt levels too low. I put it to you, that is not the case. No one in that rural area was on anything but a low salt diet. And these people, once they got through the first years of life where infectious disease killed many people, the babies, many people went on into their 60s and there was never a case of hypertension, nor diabetes, nor myocardial infarction and stroke. So I just put it to you that the suggestion that a low salt diet was dangerous in any way is absolutely not likely to be true. So what does cause raised blood pressure? Well, let's just take a look at what are the risks for what changes with so-called development from going a lower middle income country to a high income country. Well, by and large, people get older. they exercise less. Their alcohol intake goes up. Their salt intake goes up. Potassium intake, fresh fruit and vegetables, goes down. Body weight up. Stress, well, I don't know. It probably just changes from one sort of stress to another. Smoking goes up, and saturated fat intake goes up. You don't have to be an erudite medical audience to know that if that happens to a population, you're going to get cardiovascular disease. And just about all of those are risk factors. They are risk factors for raised blood pressure. We'll come back to that when we won't talk about intervening. But that, I think, these are the risk factors. My second topic about etiology of raised blood pressure, I'd just like to mention fetal programming, because I think this has sort of disappeared from the radar, and I'm not sure it should. This slide shows a summary of about 30 studies, and what it shows is the difference in systolic blood pressures. These are differences in systolic blood pressure for each kilogram weight, birth weight difference. And the story is that the smaller the baby, then the more likely you were to have higher blood pressure over the years. These are at the age of 3 blood pressures down to the age of the 70s. And what you see here is that as you get older, right the way across the age range, smaller babies tended to have higher blood pressure. And this was taken on by a guy called David Barker, and it was called the Barker hypothesis for a long time. David Barker had a knack of upsetting audiences by suggesting that all the other risk factors that many of us had worked on, blood pressure and lipids and diabetes, he said, don't worry about all that rubbish. It's all about your birth weight, which upset a fair number of people, of his colleagues. And one of the favorite excuses for saying Barker was wrong, here's the association. He found low birth weight, higher blood pressure later in life. And one of the explanations, well, this was down to confounding, for example, through the parents, socioeconomic status, maternal smoking. Mums who smoke have low birth weight babies. They're usually lower socioeconomic status. And in those sorts of families, you'd have higher blood pressure, and you'd expect the kids to have higher blood pressure, or people later in life to have higher blood pressure. So it was explained, they thought that Barker was wrong, and it was explained by confounding. So it occurred to me that if you got the same mother for the people you're comparing and looked at it there, you could get rid of all these confounders. And so we wanted to look in twins. And I had a friend who'd got a collection, a registry of twins, nearly all women, twins, and we wanted to look at them. And the plan was to look at the two pairs of twins, look at the difference in their blood pressures now, anytime in adulthood from 19 to 70 years of age, and also look at their birth weights. Now, you may say, how did they know their birth weights? But twins are slightly different. They all know, you know, I'm 4 minutes older than you, and I was bigger than you, and all the rest of it. So they tend to know those things. And indeed, I imagine 10% of this audience might know what their birth weight, but twins nearly all know. So we were able to look at the twins and get their birth weights and look at the differences in birth weight between the twins. So no birth weight difference, up to half a kilo, half to a kilo, greater than a kilo birth weight difference. And you see here we had about 1,500 pairs of twins, and we looked at their blood pressures, the differences in their blood pressures now as adults. And what you hear for the systolics, when there was no blood pressure difference between the twins, no difference in systolic. But as the difference in weight between the twins increased, you see here there's a dose-response effect on blood pressures, reaching a 5 millimeter difference, which is big at the population level and statistically significant. And the story reaffirmed this idea is that the smaller twin had higher blood pressure later in life. And we published that in the BMJ, and one of the referees said, oh, okay, well, maybe Barker's right, but only in the context of twins, which seemed unlikely. But to try and get around that, we thought, well, okay, we'll look at each of these individuals, so a few thousand of them now. We'll look at them as, just treat them as singletons and look at their birth weights, and then we'll look at their blood pressures. And what you see here is this same database, now treating each individual as 2,841 individuals. And what we've done is stratified them by quartiles of birth weight, increasing quartiles of birth weight. And we've recorded here the blood pressure. But the first thing we've done is we've also stratified it by their adult weight. Nobody argues that adult weight associated with blood pressure. The heavier you are, the higher your blood pressure, on average. And if you see here, this is adult weight. Just to make that point, going from the lightest adults to the heaviest, you see the blood pressure rises. And it doesn't matter what quartile of birth weight you're in, but if you increase your body weight as an adult, you see these big differences, the rise here, dose-response effect on blood pressure, between 7 and 10 millimeters of mercury, which is huge at a population level. But now look the other way around. Choose any quartile of adult weight, and then look at the increasing effect, or rather the reducing effect, of going from a light baby to a heavy baby. And what you see here is for any one quartile, you see this big effect. The heaviest babies in this quartile of adult weight, big difference in blood pressure. And again, and again, and again. These differences, birth weight associated, are just as big as those adult weight associated. And hard as I tried to torture the data, because I went into this thinking Barker was wrong, I couldn't make this go away. It seems to be true. And notice the difference. The lightest adults who were heaviest as children versus the lightest, the heaviest adult and the lightest baby, smallest baby, heaviest adult, the difference across here is 20 millimeters of mercury, vast. But just let me highlight again, I think this impact of birth weight on blood pressures later in life is as big as the impact of adult weight on blood pressures. And I think we've taken our eye off that ball. Now let me turn to diagnosing high blood pressure. These data were published shortly before I became president of the International Society of Hypertension. And it shows by income level of countries, the awareness, treatment, and control rate amongst hypertensives. And the key thing I want you to see is that when you look at awareness of blood pressure, it's less than half of hypertensives around the world. The total impact, less than half. Of those, nearly all of them were treated, but control rates were right down at 13.2%. So it was these data which really stimulated a drive called the May Measurement Month. But the good news, before we just go on to that, the good news is this. Notice about just under half are aware of it. That's exactly the situation that was apparent in 1994 in England. This is a random sample surveys, serial surveys carried out in England. And that awareness went from 46 to 71% in 17 years. This can be turned round. So awareness from 46 to 71%. Treatment almost doubled from a third to getting on for 2/3. Control rates almost trebled in a 17-year period. So there's great hope here. This can be turned round. But as I mentioned, because of this observation that most of the hypertensive people in the world were not aware of it, only just, but nevertheless the majority didn't know. So we launched May Measurement Month. World Hypertension Day was mentioned, was May the 17th. But it seemed to me anything that kills 10.8 million people per year deserves more than one day to focus on it. So we launched May Measurement Month to put a spotlight to increase access to blood pressure screening as potentially the most effective way to reverse the adverse toll on health due to raised blood pressure. There's no point in worrying about what the best fourth-line agent is, because that is a tiny, tiny, tiny percent of hypertensives around the world. The big gateway to getting better control is awareness, making the diagnosis, and that's why May Measurement Month was born. And we've been, since 2017, we've worked in over 100 countries, between 90 and 60, depending on COVID years, at any one time. And this shows the results of the 5 campaigns. 2020 didn't happen because of COVID. And the numbers were going very well initially, over 1.2 million screened, over 1.5 million, bigger still in 2019, then COVID struck, then a gradual reintroduction, 2/3 of a million, and then 3/4 of a million, 2022. So overall, we've screened over 5.6 million people, of whom 850,000 had got untreated hypertension, and about 500,000 had got inadequately treated hypertension. So the red figures down the bottom, what I'd like to highlight in. Through this screening, we've found over 1.3 million adults with untreated or inadequately treated hypertension. So it flags up the importance. We've raised this issue at the individual level, and there's a big social media campaign goes with it. It's out there at the population, so we hope we're making a difference, and it's carrying on at the moment. Just a quick parochial look at South Asia in 2021. India have been huge, had a huge input into the screening of this in previous years. In 2021, it was different, COVID issue. So it was a relatively small input from the Indian population. But you see here, over 1/3 of the population screened had hypertension. Of those, 2/3 were aware. That's quite good. What about those who were on treatment of the hypertensives? Well, not bad, a half. And of those who were on treatment, pretty good again, just over a half were controlled. But if you look at all the hypertensives from South Asia, about 1/3 were controlled to an old-fashioned target, which without the use of a computer, you'll realize means that 2/3 were not. And there's no reason for that. Let me now turn to trials in hypertension with a cardiovascular slant. This was the heading in a newspaper 30 years ago. This was shortly after statins were released. There was a lot of bad feeling about statins. They've been shown to lower cholesterol very effectively and cardiovascular events, but all-cause mortality had been elusive because they hadn't had the right size trial. So this appeared in the newspaper. This is not the gutter press. This is our posh, slightly left-wing newspaper, considered very erudite. Murders linked to low-fat drugs. There were 2 murders that took place in people who were in the statin trials. The first murder occurred to a gentleman who was staying in a motel, and there was a domestic argument in the room next to him. And the woman in the room next door took out her gun and shot at her husband, and she missed him. The bullet went through the wall and killed this poor guy. So he was murdered. The other murder took place with a gentleman who was taking a statin in a trial, and he heard a noise downstairs. There was a burglar. He went downstairs and he disturbed the burglar who was carrying a gun. And I assume the burglar said, "Are you taking a statin?" And he said, "Yes," and boom, shot him. That was the second murder. These people were murdered, and yet this nonsense appeared in the press. And it carried over. This drove concerns that statins would cause violent death. That only resolved when a trial called the Scandinavian Simvastatin Survival Study. This was about all-cause mortality. The 4S trial, which randomized patients to simvastatin or placebo, and the great news down the bottom, all-cause mortality was significantly reduced. And look, violent death, 3-1. No sign of a problem. No sign of a problem with cancer. All the other bits of rubbish, people were not killing themselves as a cause of being on a statin. So the concerns disappeared and people started to accept statins. And we included it in a trial called the Ascot trial of just over 19,000 hypertensives, randomized to what was the standard therapy, beta blocker thiazide, against the new regimen, a calcium channel blocker and an ACE inhibitor. But amongst those, over 10,000 patients were randomized to receive a statin against placebo. And this lipid-lowering arm was stopped early because of the big benefits, the primary endpoint, myocardial infarction, significant benefits associated with the use of statin in hypertensive patients. We published it in the Lancet on the Saturday, and on the Monday I got an email from a gentleman who introduced himself, said, "I'm an ordinary Swedish GP, about your age, I guess." I don't know how he guessed that, but nevertheless, about your age, I guess. And he said, "Congratulations, you got a paper in the Lancet, brilliant." He said, "But my takeaway message from your data is not like yours. We'd said we had to stop the trial early because of the big benefits that the statin gave." He said, no, I disagree. And he disagreed because of this. We had agreed in our analysis plan that we would publish subgroups. Beware subgroup analyses. We made a mistake. We had 18 subgroups. And here you see the different subgroups. And my Swedish GP friend, who was very ordinary, said, his interpretation of this data was that statins do not work for diabetes, they're diabetes, and they are bad for women. There you see the confidence. Bad for women, doesn't work in diabetes. Well, I wanted to suggest that he was sent back to medical school for remedial education, but that would not have gone down well. So what we did do is we expanded the power of our data to beyond the primary endpoint, shown here, to all the cardiovascular endpoints, to give us more power to be able to look in the subgroups whether there were any real differences. And there you see the result. There's diabetes and non-diabetes, absolutely no difference. Once you've got total cardiovascular events and procedures, and here's women and men, absolutely identical. But because the numbers of women included was much smaller, it didn't reach statistical significance. But you have no power if there aren't big enough numbers. So message, be careful of subgroup analysis and of ordinary Swedish GPs. The joy is that after all the fighting about statins and what drugs we should be using in the past, most of the hypertension management guidelines have come together. Recently, there's 5 lots of guidelines. They've come together and they've agreed that we should probably be starting our patients with high blood pressure with 2 drug classes at once, and ideally as a single pill combination. That begs the question, which combinations are you going to give? And I reviewed the data from the guidelines on the recommended combinations. And I've stratified it by ethnicity: black, people of African Caribbean origin, and non-black. Notice there are no data that are available here for the South Asian population, one of the biggest populations in the world. We do not have sufficient data to guess at the best combinations. But nevertheless, what you see across these guidelines, going from 2013 to 2020, for black patients, there's chaos, really. There's complete disagreement amongst the experts. The great and the good sit on these committees, and they don't agree. And the reason they don't agree is we don't have the evidence for black patients what the best combinations are. The only thing you can say is the recommendation is going to be one of these 3, A plus C or A plus D or C plus D. Let me give you the code. That's very important. A is an ACE inhibitor or an ARB. Okay, easy to remember, ACE or ARB, so it's a RAS blocker. C is a calcium channel blocker, and D is a diuretic, so it's dead easy. But the point is these guidelines are totally inconsistent because we don't have the evidence. If we look at the non-black patients, if we look at the white patients, then it's the same story. Once again, it's either 1, 2, or 3 of these combinations are recommended. But again, we don't have optimal evidence about the best combinations, even though we're recommending it to everybody to start with a combination. And let me say again, what have we got from the South Asian population? Have we any comparative data? We do not. Is there any reason to think there might be differences by ethnicity? Well, yes, there is. Going back to that Ascot trial I showed you, in the Ascot trial, you started with a beta blocker and you added a thiazide, or you were randomized to start with a calcium channel blocker and you added an ACE inhibitor. So stratified by ethnicity, look at the differences in blood pressure on systolic. When you were on a beta blocker and you added a thiazide, Europeans and Africans got good reduction. But look at the South Asians, less than half of the reduction of the other 2 ethnic groups. Now, these are tiny numbers, and we did try hard to get a broader representation, but These are tiny numbers, we can't hang our head, but suggestion this is different. Similarly, when you got those on a calcium channel blocker, adding the ACE inhibitor, big effect in the Europeans, big effect in the South Asians, but very little with the African Caribbean. So we've got suggestions, and there are other studies, there may well be differences to the best combinations by ethnicity. I'd now like to turn to, I suspect I'm going to upset some people now, but here we go. If we turn to the South Asian and Indian phenotype, you heard earlier that the coronary artery disease rates amongst the South Asians is extraordinarily high, about a 40% excess compared with the white population in UK, and a 40% excess compared in the Far East with the indigenous populations and in Africa. So there is a huge propensity for the South Asian population to have myocardial infarctions. Now, I'm going to suggest that that is because, really, of these 5 things. They have low HDL cholesterol, they have high triglycerides, they have high insulins and glucose, they have the metabolic syndrome, central adiposity, and not BMI, central adiposity, so waist-hip ratio, and limited exercise. I believe that is the reason why the South Asian population have got this 40% excess in myocardial infarction. Put simply, I now would say to you, okay, what do you get if you take a beta blocker? They make the HDL worse, they make the triglycerides worse. Glucose goes up and insulin goes up. Body weight, it's very difficult to lose weight, it goes up, and exercise capacity goes down. I do not believe this is a good drug for the South Asian population with hypertension. And I know that sticks in the claw, and it's in the latest ISH Indian guidelines. I think that's going to be contradicted, but I think that's the case. The reason I show this is that I come to India, I've had the chance to come here a lot, maybe 20 times, and given talks about hypertension management. And I finish up having a punch-up with somebody in the audience said, this is wrong, we must use beta blockers. Why? Because we have a lot of young men with a tachycardia, and these men need beta blockers to slow their pulse rate. I'm not treating their pulse rate. I want to stop them having cardiovascular events. And these are major determinants of major cardiovascular events. So my argument about this is to say, well, is there any evidence that lowering the pulse rate in hypertensive patients is going to improve their cardiovascular outcome? And I go back to the Ascot trial. Here it is again, the Ascot trial. And we considered that those randomized to the amlodipine ACE inhibitor versus those on the beta blocker thiazide may differ. The relative benefits may differ. The amlodipine ACE inhibitor was far superior overall compared with the beta blocker thiazide. Is that true by pulse rate? Well, here you see those with a pulse rate under 60, 60s, 70s, 80s, and those over 90. This is cardiovascular events associated with the amlodipine perindopril against beta blocker. There is no semblance of a benefit of the beta blocker in that situation. If anything, it gets worse with a tachycardia, but that's an unfair comparison. There is no sign. We published this in JACC, and our conclusion was the pulse rate should not affect your choice of antihypertensive medication. And that remains the case. I don't know of any evidence that's contradicted that, but yet there is this strong belief that we should be using beta blockers for South Asian patients with hypertension, uncomplicated hypertension. So what do we need? When do we need it? We need to find out what the optimal combinations treatments are for the majority of the world's population. We've done one study called the Creole study where we evaluated the 3 combos. ACE-ARB plus a calcium channel blocker, ACE-ARB plus a diuretic, calcium channel blocker plus diuretic, randomizing them into 3 groups. We didn't have enough money to have morbidity, mortality. We've done it with blood pressure, and we found out the story in Africa. And currently, in South Asia, we're running the second of the 3 of these that we plan to do. It's called Topspin. I hope you like the name. Topspin. It's multi-center, randomized, 3 arms. We need about 2,000 Indian men or women in that age group. And depending on their blood pressures, if you're on one drug already, that's your blood pressure. If you're on no drugs, it can be there. You're excluded if you've got the past medical history of these other conditions because it begets other drugs. And the idea is we're comparing amlodipine plus perindopril versus perindopril plus indapamide versus amlodipine versus indapamide. And the primary endpoint is ambulatory systolic blood pressure after 6 months. That's in progress. We're over 1,000 patients into this. And by the middle of next year, we'll have the answers. But then we need to have real cardiovascular morbidity mortality trials in the Indian population comparing regimens. So what should we be treating our patients with in the meantime around the world? Every single guideline around the world says that first-line therapy is non-pharmacological. And I won't bore you by going through the list here, but at the top of that list is salt intake, offset with potassium intake. There's a big trial in China, 21,000 adults, elderly, 60 and above, and or with a stroke, who got a thing called low salt, which is potassium-enriched salt versus ordinary salt. Those on the low salt had a significant reduction in stroke, in cardiovascular mortality, and in all-cause mortality. This is a no-brainer. We need to produce potassium-enriched salts and get it onto the shelves and replace ordinary domestic salt. My patients, albeit in a relatively low socioeconomic area in Hammersmith Hospital, when I say, what salt do you use? They say, oh, I use the pink Himalayan salt, which is expensive. The kidneys don't know where your salt came from, and they don't care whether it's pink or Himalayan or expensive. Sodium chloride is bad for you. So I persuade them to change to low salt, and we should be too. The other thing I've never understood is there's good evidence that dietine nitrate, and the best source of that is beetroots. And if you get a beetroot, the thing is it mustn't be boiled. If you boil beetroots, you're going to lose the nitrate. It's the nitrate in the beetroot that matters. So don't boil it. But if you eat beetroot, that has been shown to lower blood pressure. Actually, it was beetroot juice. There's a product called Beat It, and it was a randomized controlled trial of Beat It juice, 250 mils per day. And that lowered systolic by 8 millimeters of mercury, as good as one drug. I don't understand why that sort of thing isn't introduced throughout the lower middle income countries. It's the sort of thing that we should really be doing. All the other usual stuff, activity, weight loss. As one looks around, central obesity is a huge problem. Smoking cessation, that's a difficult relationship. Smoking and blood pressure are not as closely linked as people think. Chronic heavy smoking puts your systolic up, but for various reasons, it's a complex. But you need to stop smoking anyway for cardiovascular reasons. Alcohol, stress, caffeine, etc. Lots of things there, but I've highlighted a couple which I think deserve real focus, and particularly in India. Once we've discovered that our non-pharmacological measures are not sufficient, or if we've discovered that, we then go to the drugs. And this is the sort of thing you can expect from drugs if you lower the blood pressure by 10 millimeters of mercury. That's all, and we can lower blood pressure by a lot more than that. You get these huge benefits in cardiovascular events, so we should be doing it. What drugs should we use until we've got definitive evidence in India, for example, for the right drugs to start with, whether it's 1, 2, or 3 of them? This table from the International Society of Hypertension, I think, says it all. We want treatments that are evidence-based in relation to morbidity and mortality prevention. In India, we don't have that. We should be using agents that give 24-hour blood pressure control. Once-a-day regimens is what we need, and there are lots of those available. Thirdly, the drug's got to be affordable and or cost-effective relative to other agents, and I realize that could be a huge problem in many parts of the world. Fourthly, the drug's got to be well tolerated. If it isn't well tolerated, people are not going to take it. And finally, another dig for trials here is we want the evidence of benefits of the use of the medication in populations to which it is to be applied, whether it's post-stroke whether it's the very elderly, whether it's in diabetes. We want that evidence that is context-specific. Finally, ladies and gentlemen, to summarize what I hope I've just said, is that high blood pressure is the top priority in global health. We need to focus on prevention, and that means educating everybody, the general population, through all healthcare professionals, right the way through the range. And we need to have health promotion of healthy products, beetroot juice, low salt. We need to improve the diagnosis. We have to enhance screening of blood pressure, making it routine, opportunistic screening routinely for everybody, because you cannot treat what has not been diagnosed. So we've got to screen for blood pressure. And finally, I think our management has got to be improved. We've got to find out the best evidence by ethnicity around the world, and then we need to prove as single pill combinations, cheap versions, and they've got to be distributed equitably and delivered around the world. If we can deliver Coca-Cola, which kills, all around the world, every small village in the world has got Coca-Cola in it, surely we can get cheap antihypertensive agents there, and we should be trying to do that. And finally, we appreciate that there aren't enough doctors about. Doctors don't need to treat hypertension. Community health workers can look after the vast majority. They should have simple algorithms with possible support from eHealth. If we do that, we'll make a huge difference. Thank you for your attention.
I request all of you to kindly remain seated. Thank you so much, sir. Words actually fall short to express our gratitude towards you for delivering this extremely informative and enlightening talk. It is absolutely overwhelming to witness the amount of research that you have contributed to in the field of management of hypertension. And your talk has undoubtedly given a deep insight into the field of preventive hypertension. It is time to felicitate Dr. Neil Poulter for this wonderful oration. May I request the dignitaries to please come in the center of the stage for the felicitation ceremony. So can we hear it once again for today's oration as a mark of our gratitude? We're presenting, sir, with a shawl. May I request the Emeritus Chairperson, Dr. M.L. Swankar, to felicitate Dr. Neil Poulter. I request the Chairperson cum Chancellor, Dr. Vikas Swankar, to present the plaque, citation plaque. I also request you, sir, to please present him with the citation scroll. The citation scroll to Dr. Neil Poulter.
And at this moment, can I request all of you to please rise at your places to give a standing ovation? I request Dr. Rajiv Gupta and Dr. Sanjeev Gupta to present another memento. I request Dr. Sudhir Sachdev and Dr. Achal Gulati sir to present a bouquet also along with the other felicitations. And requesting the Emeritus Chairperson, Dr. M.L. Swankar, to present the Oration Honorarium to Dr. Neil Poulter for delivering this wonderful, wonderful oration. And can we hear it aloud? Thank you so much, sir, for accepting this invitation, for gracing our organization.
आवाज लंदन तक जानी चाहिए.
Thank you all. Kindly be seated. And sir, may I request you to say a few? Aja, okay. Sir, would you like to say a few words, Dr. Neil, please? Mic.
Won't need that, will we? Distinguished friends and colleagues, ladies and gentlemen, thank you very much indeed. This really has been a huge honor for me to be asked to deliver this KD Gupta oration. I'm truly flattered and humbled by the kind words and the hospitality I've received in this reception. You have to appreciate, I'll go home to my house and the only famous person there is my son. So that will be a huge change. So thank you. Earlier today I had a whistle-stop tour of the Mahatma Gandhi Hospital and the grounds, and all I can say is that it's an absolute stunning experience for me. As I mentioned, I'll go home to my small clinic in my small hospital, and having seen what I've seen here, it's a huge stimulus and inspiration, and a real world leader, just stunning expansion with excitement written all over the place. I talked during my, perhaps too long from your point of view, but I talked about hypertension because it's close to my heart. It's what I've done for a long time. But just let me repeat, it's close to all our hearts. Treating high blood pressure is low-hanging fruit. It's easy to measure it. And assuming we've got the drugs and we must get them, it's easy to treat too, by and large. But let me emphasize again, I'm duty-bound to say, prevention is definitely better than cure. We need to I guess all the undergraduates in the audience, you didn't go to medical school to prevent things. You went there to treat the sick. But you need to expand your horizons to encompass preempting that illness happens. Bearing in mind that no one will ever come up to you and say, thank you for preventing my heart attack that I haven't had. That won't happen. So be prepared to be disappointed by that, but the good you will do at a population level will far outstrip individual treatment. Finally, last night, Achal Gulati said, as Vice-Chancellor, he said that he feels that I've arrived here as a friend of colleagues, many we've worked together for a long time. but he said that hopefully I would leave as part of the family. It would really be a huge honor to feel that I was part of the families. The Swankar and Gupta families have been incredibly generous to me, and I'm truly honored for that they have asked me. To the students, I just wish you all the very best in your endeavors, and thank you for coming along today.
Thank you once again, sir. I now humbly request the Emeritus Chairperson of Mahatma Gandhi University, Dr. M.L. Swankar, to address us on this occasion. Thank you, sir, for inculcating such values in all the students and faculty of this organization.
Thank you, friends. Thank you, respected Professor Neil Poulter ji, Dr. Achal Gulati ji, Dr. Rajiv Gupta, Sanjeev Gupta ji, Dr. Rajiv Bagaretta ji, Chairman and Chancellor Dr. Vikas Swankar, Pro-Chancellor Dr. Kapoor, our former Vice Chancellor Dr. Sudhir Sachdev, now the advisor of the Chairman, Dr. Andy Soni, all the distinguished guests who have come from far away to those who were from the Bikaner Medical College studied when Dr. K.D. Gupta was principal and professor and head of medicine. So it is a great opportunity, and we all are honored to listen to your very simple and very effective talk, which is, I mean, majority of the people are affected with hypertension because of the lifestyle problems. There's less of genetic and more of the environmental. So if we follow the evidence-based medicine, and if we follow our old tradition of balanced lifestyle, balance in food habits, balance in work habits, everything. So if we combine two, then things will improve in a much better way, and we can save many lives. And what he said, that maybe you may not get the recognition by prevention as by treating one individual or two individual or little more, but the amount of the benefit you will give to the society, that has to be measured. Your popularity does not matter. It is the matter, what matter is the benefit for the society, how much you do for society. The service to the society is service to the God. This has to be very, very, very clear in each and every medical or health worker or student or those who are pursuing medicines. I will not take much time because the program is going quite long. Lunch hours are, people are there who have come all the way and listening to all the distinguished guests. We have many distinguished guests, and one of the faculty who will be joining us is sitting here, Dr. Ashok Gupta, who was formerly professor of pediatrics and rare diseases in children, genetic diseases. So he will be the director of pediatric sciences and director of rare diseases. So we welcome you, Dr. Ashok Gupta, and it's a wonderful day. What a combination that in a simple way and very effective way, you can understand the depth. Any person who has the knowledge, real knowledge, will always simplify the things, always simplify the things. And this is what Professor Neil Poulter has done. So I'm sure Dr. Ashok Gupta will do same. And we have amongst us Dr. Raja Babu Pamarji, who was Vice Chancellor of Rajasthan University of Health Sciences, for almost 10 years, student of Dr. K.D. Gupta ji. Many friends from Bikaner Medical College like Dr. Subhas Rajput, who worked day and night to invite people. So we thank Dr. Subhas Rajput. I have my friend Dr. O.P. Sharma from Sikar. He has also done hard work in inviting people, those who have come all the way from Bikaner. Dr. Rajiv Guptaji's family is sitting here. My family and other distinguished doctors are sitting here. Dr. Nahata is from Bikaner Medical College, my colleague. So a lot of friends are there. So I owe a great thanks to them for making this event successful. And Dr. Neil, we have no words to express our gratitude. The way you have explained the hypertension, I think many of us will leave the habit of taking fast food, Coca-Colas and other things, and low salt intake, do the exercise and make their life better for themselves, for their families and for their children. Thank you very much.
Thank you, sir. With this, we come to the end of this program. I invite Dr. Rajiv Gupta to deliver the vote of thanks.
Thank you very much, and I'll be very brief. First of all, let me thank Professor Poulter to accept our invitation to be here. And he was here for the Prevention Cardiology Conference. And what he told me that he is more interested in oration than the conference. So I think that shows his commitment to the undergraduate students, to the postgraduate students, to the young faculty of an institution, so that he can impart his knowledge. And the second comment I'd like to make is, he has made hypertension simple. But I think what I use the term is deceptively simple, because it's a lifelong commitment on the part of the patient, as well as the doctors who treat these people. And about the prevention thing, I think prevention the patient may not tell you that may not thank you that you have prevented heart attacks, but in your mind, at the end of your life, you'll feel happy that you could prevent so many of these things. So finally, may I request Professor Poulter to present a memento to the chairperson of the university, Dr. Swankar. Thank you very much, and it's my great pleasure to thank all of you for being here. Thank you very much.
Thank you, one and all. Thank you, the dignitaries on the dais and off the dais. May I request all of you to please rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंग तव शुभ नामे जागे तव शुभ आशीष मांगे तब जय गाथा जनगण मंगलदायक जय हे जय 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 हे.
All guests and faculty members are invited for lunch at the Grand Cafe RK block, that is the Radha Krishnan block. Please join for lunch.